Hello, and thank you for joining us today on this webinar sponsored by Virta Health. I'm Robert Ratner. I'm currently the Chief Medical Officer here at Virta, and I'll be your moderator and host today. I've had the great pleasure and honor of participating in a number of sessions related to diabetes remission over the last 15 years, going back to John Buse's original paper on diabetes remission. We're now coming full cycle, and we have an absolutely superb group today to discuss the new developments and the new criteria for diabetes remission. I want to begin with a few housekeeping notes. This webinar will be recorded, and we'll send the recording to all the guests, so you will be able to have a firm copy of this. Towards the end, we'll have a few minutes for Q&A. Please put your questions into the question box on Zoom, and we'll get to as many of them as we can. I want to take a moment to really introduce our panelists because we have a truly superb group of individuals. Dr. Amy Rothberg is professor in the Division of Metabolism, Endocrinology, and Diabetes, and professor of Nutritional Sciences in the School of Public Health, both at the University of Michigan in Ann Arbor. She's the director of the University of Michigan Weight Management Program, and primary research interests are all funded by NIDDK and NICHD for studies examining the neurobiopsychosocial aspects of obesity and its related metabolic diseases. Dr. Rothberg is a member of the consensus panel that wrote and authored these recommendations. Our second speaker will be Dr. Philip Schauer, the Mary Kay and Terrell Brown Harris J. Schutz Endowed Professor of Metabolic Surgery at Pennington Biomedical Research Center of Louisiana State University in Baton Rouge. He's director of the Bariatric and Metabolic Institute at Pennington, and he's formerly professor of surgery at the Cleveland Clinic, Lerner College of Medicine. He's past president of the American Society for Metabolic and Bariatric Surgery, and he also is a consensus panel member and author. Our final speaker will be Dr. Amy McKenzie, the Director of Research and Innovation at Virta Health, where her research focuses on applications of carbohydrate-restricted nutrition therapy delivered through Virta's care model, interventions to augment outcomes for Virta's patients, and relationships between nutritional ketosis and health outcomes. She has received Young Investigator Awards from the National Lipid Association and the American Diabetes Association. With that, what I'd like to do is turn this over to Dr. Amy Rothberg to give us a review of the consensus panel process and recommendations. Dr. Rothberg, please.
Thank you very much, Bob. It's a pleasure to be here. I'm actually very excited to be here and to share sort of the key points of the consensus report on type 2 diabetes remission. So once again, I'm going to walk us through the consensus report definition and interpretation of remission in type 2 diabetes. This was published simultaneously in 4 peer-reviewed journals, including Diabetes Care, Journal of Clinical Endocrinology and Metabolism, Diabetic Medicine, and Diabetologia. And here are the members of the writing group, including Matthew Riddle, who happens to be not only the senior author, but editor of Diabetes Care. And of course, we were also joined by Phil Schauer. So I just want to take 1 second to talk about managing type 2 diabetes. There has been a much needed paradigm shift in that we now recognize that we need to treat obesity or manage obesity in order to effectively treat type 2 diabetes. And we recognize that glycemia can revert to normal in some people with type 2 diabetes, either spontaneously or after medical or surgical interventions. And in some people, normal glycemia can persist after withdrawal of glucose-lowering pharmacotherapy. But the terminology for describing this process and objective measures for defining it were lacking. and long-term risks versus benefits of attaining normal glycemia were not well defined. So therapies targeting metabolic control in type 2 diabetes have vastly improved, and some result in substantial weight loss and have pleiotropic effects, such as the glucagon-like peptide receptor agonist, or GLP-1RAs, and sodium glucose cotransporter 2 inhibitors, or SGLT2 inhibitors. Of course, surgery and endoluminal interventions have led to metabolic improvements, and the cornerstone of therapy, intensive behavioral lifestyle management. And because we've experienced sustained improvements in glycemia, this has highlighted the need to reevaluate the terminology and definition of diabetes remission to guide future clinical care and research. For the purpose of the 2021 or updated and revised consensus statement was to propose suitable definitions of terms and ways to assess glycemic control to facilitate collection and analysis of data that may lead to future clinical guidance. Remission of type 2 diabetes was found to be the appropriate term. This was not changed from the 2009 consensus report, and this is based on experience with cancer and other long-term chronic diseases, such as HIV/AIDS. Remission is defined as the abatement of or disappearance of the signs and symptoms. So unlike the consensus statement from 2009 regarding remission, we distilled our definition of remission into a single definition. And just to remind the audience, in 2009, consensus authors stratified remission into 3 categories. Those being partial, defined as a blood glucose below the diagnostic thresholds without active pharmacotherapy for at least 1 year. Complete remission, that is a normal blood glucose without active pharmacotherapy for at least a year, and prolonged complete remission that persisted for 5 years or greater. But the authors recognized that these distinctions tended to introduce some ambiguity regarding coding of encounters and therefore reimbursement from the payers. And further, that this prolonged remission of 5 years had really no objective basis. So the criteria are the following. Remission should be defined as a return of hemoglobin A1C of less than 6.5% that occurs spontaneously or following an intervention and persists for at least 3 months in the absence of usual glucose-lowering pharmacotherapy. I'm going to pivot for just 1 second and just show this rather sobering statistic. Life expectancy is still reduced 6 years by type 2 diabetes, despite guidelines and drugs to lower glucose, hemoglobin A1C, LDL cholesterol, and blood pressure. And worldwide, there are 488 different drugs licensed to treat type 2 diabetes. And here, as I'm showing you graphically, overnutrition, weight gain, obesity are the main drivers of type 2 diabetes. Here, I'm just showing you the age-adjusted relative risk of developing type 2 diabetes across BMI strata. So when hemoglobin A1C is determined to be an unreliable marker of long-term glycemic control, we use fasting plasma glucose of less than 126 milligrams per deciliter, or an estimated hemoglobin A1C of less than 6.5%, calculated from continuous glucose monitoring values as alternate criteria. Here I'm just showing a table derived from the consensus report, reviewing the interventions and temporal factors in determining remission of type 2 diabetes. And as you can see, the interval before testing of hemoglobin A1C is of 3 months or greater after cessation of the treatment. Now, whether a therapy needs to be discontinued really depends on the intervention. Let's just keep in mind that surgery is rarely reversed so that it's always ongoing. One could possibly argue the same for lifestyle. But whether remission can be diagnosed in the setting of drug treatment is a far more complex question with which we on the committee struggled. So, a diagnosis of remission can only be made after all glucose-lowering agents have been withheld for an interval that is sufficient both to allow waning of the drug's effects and to assess the effect of the absence of drugs on hemoglobin A1C values or other diagnostic criteria, even when glucose-lowering therapies are used for other purposes. For example, the SGLT2 inhibitors being prescribed for heart failure or renal protection, or the GLP-1 receptor agonist for cardiovascular risk reduction or weight loss, and metformin for PCOS or for its purported downstream positive effects. In the case of any of those, stopping any of them may be prohibitive or not feasible or simply not worthwhile. But in the case of continuing, diabetes remission really cannot be known. Metformin was actually or proved to be the albatross in our discussions, particularly because it is ubiquitously prescribed for a panoply of conditions, and more specifically for the treatment of prediabetes. The group also recognized that some drugs have a modest glucose-lowering effect, but are not indicated for glucose lowering, as in the case of some weight loss drugs. Also, we need to persist with ongoing monitoring. Subsequent testing to determine long-term maintenance of remission should be done at least yearly, together with the testing routinely recommended for potential complications of diabetes. So including annual dilated eye exams, regular foot exams, screening for microalbuminuria. We also need to help our patients or facilitate ongoing adherence to a healthy lifestyle. The risks and benefits of therapies that potentiate weight gain or hyperglycemia also need to be carefully considered and these therapies avoided whenever possible. So the consensus statement is based upon expert opinion, and there are some limitations. It proposes terminology and a framework for discussion to facilitate future research and support future clinical guidelines, but is not a clinical guideline. Areas that we identified as needing further research include validating the use of hemoglobin cut point of less than 6.5% and timing of glycemic measurements, evaluation of the effects of metformin and other drugs after remission is established, and after diagnosis of remission, the non-glycemic therapeutic role of metformin and other drugs need to be established. We need to, again, evaluate the non-glycemic measures during remission. That is, what's the role of changes in neurohormones and peptides after behavioral, pharmacologic, and/or surgical interventions in altering the risks of relapse or other clinical outcomes. And then finally, we need to further research the duration of remission given the various interventions and how data are collected and analyzed. And I will end with that, and I will stop sharing my screen.
Thank you very much, Dr. Rothberg. We very much appreciate the background presentation. Let's now move to Dr. Phil Schauer to discuss the ramifications of metabolic surgery as it pertains to diabetes remission. Dr. Schauer was also a member of the consensus panel. Dr. Schauer?
Thank you, Dr. Ratner, for the invitation to participate in this consensus conference on remission of type 2 diabetes. Well, I'll be talking about metabolic surgery as a mechanism to achieve type 2 diabetes remission. Now, in terms of the types of interventions that we know that can potentially achieve remission are the following: very intense lifestyle intervention through diet and exercise can potentially convert a patient with diabetes to non-diabetic. Also, very short-term intensive medication, for example, with insulin, can cause beta cell rest, which can lead at least to temporary remission. And then finally, metabolic surgery, which is what I will be focusing on in this talk. Now, here we are in 2021 with the 4 common types of bariatric surgery. And the first 2, sleeve gastrectomy and gastric bypass on the far left, represent the most common forms of bariatric or metabolic surgery today, representing the vast majority of these cases. Gastric banding was quite popular a decade or so ago, but that has really fallen out of favor. And the biliopancreatic diversion or duodenal switch, which is an operation that reduces gastric volume, but also causes or a large amount of bypass of the intestines, that is less commonly performed throughout the globe. Now, there's been a lot of progress in the field as demonstrated in this graphic. In the blue bars, you see from the early 90s to just a few years ago, the growth in the number of procedures performed in the United States, very steady growth rate. Up until now, in 2021, we are performing more than 250,000 operations per year, which is still only a fraction of those people who actually qualify for surgery. And in the yellow and red, you see actual changes in complication rates and mortality. You can see in the late 90s, complication rates were as high as 12% and mortality around 1%. But these have improved dramatically such that, and nowadays, major complication rates are around 1% and mortality of the surgery is around 0.1%. And a lot of that is due to the advent of laparoscopic surgery in the late 1990s, which dramatically reduced complications and improved the safety of these procedures. Now, a seminal event occurred early in the 1990s when Walter Porres published his work, one of the first to actually show metabolic surgery can lead to type 2 diabetes. And here is his initial study published in 1995 with a very provocative title. Who would have thought it? An operation proved to be the most effective therapy for adult onset type 2 diabetes. And in this study, he showed that metabolic surgery, in this case, gastric bypass, could lead to an 81% remission. Now, it wasn't called remission in those days, but converted people from diabetes to being non-diabetic. Now, interestingly, that was in the early 90s. It somewhat fell on deaf ears, at least in the medical community. Surgeons were really excited about this, but our endocrinology colleagues were not so excited about this finding. And this is when I became interested in the field. And just a few years later, I published one of the first series and largest series on laparoscopic gastric bypass, 275 patients. And in this series, 18 of those 275 had diabetes. And after about a year and a half of follow-up, 82% of those patients with diabetes became non-diabetic, or we would say now were in remission. Then I followed that study up with a study that was exclusive to patients with type 2 diabetes, a much larger sample, almost 200 patients, and found very similarly a remission rate of 83%. And in this study, it was large enough that we could look at determinants of remission. And we found that individuals who had the shortest duration of diabetes and the mildest form of diabetes were the ones that had the greatest probability of achieving remission. So this led me to design a randomized controlled trial. We also got NIH funding. This is when I was at the University of Pittsburgh, and we joined the Labs Consortium. It took me a while to get the funding for a randomized controlled trial, but we had one of the first randomized controlled trials called Stampede. And this study, our initial results were published in 2012, and then 3-year results in 2014, and then the 5-year longer-term results published in 2017 in New England Journal of Medicine. This was funded by industry as well as funding from NIH. Here's the design of the trial. 150 patients were randomized to either intensive medical therapy, which was determined by ADA guidelines, lifestyle intervention, which included low-calorie diet, not very low calorie, but low-calorie dieting, and medical therapy with the goal to achieve an A1C of 6% or less. So our endocrinologists were asked to keep adding medications until the A1C got to less than 6%, and they were followed quite frequently over time. Patients were also randomized to gastric bypass or sleeve gastrectomy. So this was a 3-arm randomized controlled trial comparing the 2 most common operations with intensive medical therapy. Now, this shows you the baseline characteristics of the 3 study groups. This is important because these individuals had advanced diabetes, actually more advanced than the group that was involved in my first publication. And you can see here the average A1C was nearly 9%. Patients had more than 8 years of duration of diabetes on average. The body mass index on average was 36. The range was from 27 up to about 43. Most of the patients were on polypharmacy, and nearly half the patients were on insulin. So this is a group that had fairly advanced diabetes and were in fairly poor control on polypharmacy prior to the study. And this shows you the A1C curves compared to baseline. In the medical therapy group, you see a nice improvement with more intense dietary and medical treatment, but that was not well sustained out for the 5 years. In the 2 surgical groups, you see quite a significant improvement in A1C, a drop of about 2.5 absolute percentage points, which is quite significant, which was fairly well sustained out to 5 years, such that at the 5-year mark, most of the patients in the medical group were no better off or actually a little bit worse than they were 5 years before, whereas in the surgical group, the vast majority were better off than they were 5 years before. And while none of the patients in the medical group achieved remission, a little more than 30% achieved remission with gastric bypass, and 23% achieved 5-year remission with sleeve gastrectomy. This shows you the change in body mass index. This is to point out that the patients in the medical group did have some weight loss, which we think is important for so-called dietary remission approaches, but fairly modest 2 BMI point drop, which is about a 5% weight loss overall, much less compared to what we see with the gastric bypass and sleeve gastrectomy. Another important point is the reduction in medications at 5 years. The patients in the medical arm still required large amounts of insulin and oral agents, whereas those who had surgery, especially gastric bypass, were able to decrease their medications significantly. In fact, those who had gastric bypass, 45% were off all their medications completely. And this was also true, but to a lesser extent, for sleeve gastrectomy. We saw similar trends with other medications, cardiovascular meds, for example, for treating blood pressure and lipids as well, a big reduction. Now, apart from the STAMPEDE trial results, there have been now 12 randomized controlled trials. These are relatively small studies with sample sizes anywhere from about 50 up to 150. I've highlighted here the STAMPEDE trial, comparing various different operations, either gastric bypass, gastric banding, or sleeve gastrectomy with intensive medical therapy to achieve improvement in glycemia and or remission. Now notice here, the remission of diabetes was not so solidified in terms of the definition in these days. And you can see anywhere from, in Stampede, it was 6% or less. In others, it was 6.5% or less without medications. But virtually in all of these studies, they show that surgery was superior to the medical approach for treating type 2 diabetes. There was one exception, the study third from the bottom by Ding and others. This was comparing gastric banding with medical treatment, and this study was not statistically significant in showing superiority of gastric banding over medical treatment, but that was really no surprise. Now, there have been 4 studies, 4 randomized controlled trials that have 5-year follow-up. And here they are showing you the relative remission rates of medical therapy, gastric bypass, sleeve gastrectomy, and BPD. And again, these were studies that involved patients generally that had more advanced diabetes. So we see remission rates for surgery in the 30% plus range, and only one of these studies showed remission for medical or dietary intervention. And the determinants of remission, of course, what I mentioned earlier, were duration of diabetes, number of diabetes medications, insulin usage, all of which are surrogate markers for beta cell function. We now have just published a few months ago the 10-year follow-up of the Mangroni-Rubino study. And this shows you the diabetes-free survival probability or remission rates going out to 10 years. And at 10 years, we see a remission rate of 50% for the BPD and 25% for gastric bypass. So over time, and this seems to be true with all therapies, we do see a degradation of complete remission over time. So this is something very important to consider when we talk about remission. And finally, I want to show you some data on the implications of effective treatment and or remission, and that is the reduction in long-term morbidity and mortality. And this is a study conducted when I was at the Cleveland Clinic involving over 2,000 patients who had metabolic surgery, matched 1 to 5 with patients who did not have metabolic surgery but had very similar demographic characteristics. And we found after 8 years of follow-up that metabolic surgery was associated with a 41% reduction in mortality, 62% reduction in new onset heart failure, 31% reduction in development of coronary artery disease, 33% reduction in stroke, 60% reduction in nephropathy, and a 22% reduction in atrial fibrillation. And you only had to treat 13 patients to save 1 life, which is a very relatively low number to treat to achieve that endpoint. And then I wanted to share with you a very recent, very large meta-analysis published in Lancet just a few months ago. And this shows you the mortality curves in over 174,000 patients, comparing metabolic surgery with those who did not have surgery, and they were matched for, again, key demographic features. And you see here about a 49% reduction in mortality, which is really quite extraordinary mortality reduction for any type of intervention for patients with diabetes. So if I conclude, what's next, future directions? While there's quite a large amount of data supporting surgery, what we don't have is a prospective multi-center randomized controlled trial. In other words, a cardiovascular outcome trial for metabolic surgery. I think we really should try to achieve this. I am working with a number of investigators to try to realize this dream, and we're calling the trial DREAMS: Diabetes Reduces Effectively after medications or metabolic surgery. Perhaps I should call this after medical treatment or metabolic surgery dreams. Please help us support the funding organizations that would likely fund this study. So in conclusion, what is the take home? Well, metabolic surgery, based on 12 randomized controlled trials, appears to be more effective than intensive medical therapy for treating diabetes. Of course, it depends on just how you define intensive medical therapy. Surgery can achieve not only remission, but long-term remission, and it varies between 30 up to 80%. And of course, that's determined by the severity of the diabetes at the time of intervention, which is really a surrogate marker for beta cell function. Observational studies show reduced morbidity and mortality from metabolic surgery. And we now have many organizations like the ADA who endorse metabolic surgery as a treatment and potential intervention that can lead to long-term remission of diabetes. Hopefully someday we will have this multi-center randomized trial to really end the debate about the role of surgery. And then finally, and most importantly, I do think, medical doctors and surgeons, we should all work together using all the tools that we have to treat our patients with diabetes, and in some cases, actually render long-term remission, just like these scientists did in a multidisciplinary fashion 100 years ago to come up with the single most important advancement in the history of diabetes, the discovery of insulin. I do want to acknowledge the investigators at the Cleveland Clinic who helped me conduct many of these studies that I just mentioned. Thank you very much for your attention, and I look forward to participating in the panel discussion shortly. Thank you very much.
Thank you, Dr. Schauer. So you've heard how we came to definitions on remission. You've heard about the impact of surgery. Now let's look at the impact of lifestyle. Dr. McKenzie, the time is yours.
Thank you, Dr. Etner. All right, so my disclosures for today. And today I'll share with you a little bit about the history and the evidence for carbohydrate-restricted nutrition therapy for remission in diabetes and why reversal and remission are important for patients with type 2. Now, we've talked a lot about remission, and the committee that put together the consensus statement also identified reversal as being different from remission, but referring to the process of lowering A1C below the diabetes threshold. So I want to talk about both reversal and remission today. But to start, I want to take a historical perspective. I want to start with how we treated diabetes more than 100 years ago, before the discovery of insulin. And I think thanks to the pioneering work done by Dr. Elliot Joslin and Dr. Frederick Allen, we learned that people with diabetes could be treated entirely with diet by significantly restricting carbohydrate intake. What people with diabetes ate before 1921 looks a lot like what very low carbohydrate and ketogenic diets look like today. People can consume non-starchy vegetables, salads, meats, poultry, fish, various different kinds of flours, nuts, fruits, and cheeses. And doctors learned very quickly the value of adding adequate fat to provide enough calories to patients. But I think over time, a lot has changed in diabetes. First, with the discovery of insulin 100 years ago, like Dr. Schauer just mentioned, and as many new classes and generations of drugs came on the market, we moved heavily into pharmacological management, including for people with type 2 diabetes. And I think the fact that diet could be helpful, if not life-saving, got a bit lost. So let's take a look at what the experts say about carbohydrate restriction today. This is from the American Diabetes Association consensus statement on nutrition therapy. They address what a low carbohydrate diet is. It's one that emphasizes the foods low in carbs that I mentioned before, resulting in 26 to 45% of daily energy from carbs, lower than average, but certainly not very low. Now let's take it one step further to a very low carbohydrate diet. Same foods, but less than 26% of energy from carbs. Often people aim to consume less than 50 grams of carbs per day to induce nutritional ketosis. This is a physiological state that allows fats to be used more efficiently for fuel and elicits other metabolic benefits like reduced inflammation. Some other benefits are A1C reduction, weight loss, lowering blood pressure, lowering triglycerides, and improving HDL-C for patients. And what we generally see is that the greater the carb restriction, the greater the benefit. But how much evidence is there really for carbohydrate restriction? And I'm happy to say that the answer is a lot. The ADA standards of medical care say that reducing carbohydrate intake has the most evidence for improving glycemia from a nutrition perspective. And the consensus report on nutrition acknowledges that low carb eating patterns are among the most studied patterns for type 2. So what about this evidence? I want to share some of the evidence for very low carb diets with a special focus on A1C and medication outcomes, as though those are the two ingredients in the diabetes remission definition. There are many more studies that I don't have time to share today, but I want to give you a bit of the historical view of what we knew when we designed our own research study on this topic, and then share some of our research findings. So one thing we knew is that a very low carb ketogenic diet worked very quickly. This was a metabolic ward study by Bowden and colleagues. People with type 2 diabetes were given a buffet of food that was appropriate for a ketogenic diet, allowed to make all their own food choices. They ultimately ate around 21 grams of carbs per day. And in 2 weeks, they saw significant reductions in A1C and meds, improvements in insulin sensitivity, even prior to significant weight loss, perhaps similar to what we see immediately post-metabolic surgery. But in both cases, the question quickly becomes one of sustainability of these effects. So now let's take a look at 3 months. This was a randomized study by Laura Saslow and colleagues comparing a very low carb ketogenic diet to a moderate carb intake. And the very low carb ketogenic group had a significant decrease in A1C and medication elimination for nearly half of the patients. And there were greater improvements for the low carb ketogenic group compared to the moderate carb group. Same study out to 6 and 12 months, we see the same thing, sustained reductions in A1C and medications. And there was also a study by Irshai published in the New England Journal, a 2-year randomized controlled trial of low carb versus Mediterranean versus low fat. And at 2 years, among those with type 2 diabetes, reduction in A1C was only significant in the low carb group. So this was really the state of the evidence in 2015 when we were thinking about a trial. We knew that carbohydrate restriction was beneficial, but the trials were small and there was really a lot that we didn't know or we didn't have a practical solution for outside of research. We needed to know what happened to patients on insulin. How do we safely deprescribe medication to those patients in the real world? What happens to patients with longer durations of type 2 diabetes? What about the long-term retention and adherence over several years? How do we personalize this to each patient as their life circumstance changes? And ultimately, what happens to diabetes? Can they get an A1C below 6.5 and stop all meds? We certainly wanted to know all of these things, and we wanted to be able to address these challenges. And we kind of felt that the existing brick and mortar clinics and the episodic telemedicine visits that were just becoming very popular weren't going to cut it. So at Virta, we created a new care model, and this is one that would deliver the carbohydrate restricted nutrition therapy through a continuous remote care platform to give people ongoing access to their care team and to give the care team ongoing access to their patients' data to proactively and reactively take care of the patients. So we put this care model to the test in a 2-year open label, non-randomized controlled trial to assess the effects of this new care model, as well as the usual care model of utilizing diabetes education classes and seeing their doctor occasionally. And at the end of that 2-year trial, we actually offered patients the ability to reconsent and participate in a 3-year follow-up, bringing their participation out to 5 years. We just finished collecting that data and look forward to sharing it in the future, but today I will focus on the 2-year data. So a little bit about the patients who enrolled. There were 262 patients who chose Virta. 90% had obesity. A1C was in the mid-7s. Patients had diabetes for more than 8 years on average, more than other trials who were looking at remission. The majority of patients were on diabetes meds. 30% took insulin, and it was actually our protocol to not deprescribe metformin. Like Dr. Rothberg mentioned earlier, there are many reasons for doing that, including use in other conditions and the recommendations according to the standards of care. At the time, evidence for SGLT2s and GLP-1s and their non-glycemic indications wasn't where it is today, but certainly I think this falls into the same category, and I think will be an even bigger part of the discussion in the future. So to answer the first question about sustainability, I think we can confidently say that this is sustainable. 74% of patients were retained in the intervention for 2 years. And among those patients, A1C declined by 0.9 to 6.7 on average. Reduction in glucose prompted rapid and sustained deprescription of medication across all of the classes. 69% of the prescription changes that happened for meds other than metformin were deprescriptions, completely discontinuing the med. And while I've focused a lot on A1C and medication reductions, I think it's important to note that patients experienced broad spectrum health benefits extending beyond type 2. This included things like 12% weight loss, reducing inflammation, improvements in markers of cardiovascular risk, and that happened concurrent with no evidence of worsening of atherosclerosis as measured by carotid intima media thickness. We also saw improvements in surrogate markers of fatty liver and fibrosis. 62% of patients discontinued insulin, and for those who remained on it, they needed 81% less. Medications outside of diabetes, like diuretics that were used for hypertension, were able to be deprescribed as well. So I've shared a lot of evidence for carb-restricted nutrition therapy to reduce A1C in meds, but there are other lifestyle interventions that can achieve remission. Remission consensus statement cites these two really well done randomized controlled trials in diabetes. First being the DIRECT trial that was performed in the UK, where primary care clinics were cluster randomized to implement a weight loss program that utilized a low-calorie formula diet or to follow standard of care. The other being the US-based Look Ahead trial, which utilized clinical research centers to deliver the therapies. Participants were randomized to either an intensive lifestyle intervention that used a combination of low-calorie formula diet replacements, fat and calorie-restricted nutrition therapy, and increased physical activity, or they were randomized to general diabetes support and education. Remission was observed in about 10% of the participants in the intensive intervention in Look Ahead at 2 years. And like Dr. Schauer has mentioned, shorter duration of diabetes was associated with greater likelihood of remission. So you can see that when they set up the DIRECT trial, they more or less cherry-picked the population to be the group that's most likely to be able to achieve remission. And they excluded anyone with diabetes for more than 6 years. So on average, participants in that trial had diabetes for about 3 years. They stopped all medications, including metformin, on day 1. And under these conditions, 36% were able to achieve their definition of remission at 2 years. So now I want to add in the research on Virta's intervention and care model as well. In our trial, we took more of the approach that Dr. Schauer did in the STAMPEDE trial, and we accepted all comers regardless of how long they had type 2. And our participants had diabetes for more than 8 years on average. After being treated for 2 years, we reported that 19% achieved remission according to the 2009 ADA consensus definition of remission from Buse et al., which is what we had at the time. And then, of course, when the new consensus came out, we were excited to go back and reanalyze the data according to the new definition. And we found that 25% achieved this designation. So like others, those with shorter duration of diabetes were more likely to achieve remission, but we did see some success with longer duration of diabetes out to 18 years. Remember, this 25% remission is in the context of not actively deprescribing meds in these patients, another key difference between some of the trials. So I want to look at the spectrum of diabetes reversal and remission. Here we have the 25% of patients treated 2 years according to the new definition. This is an incredible achievement, and having the standard definition is critical, but I think the reality of day-to-day patient care is a little bit less black and white than this. We've seen over and over again that remission is more likely among those who are newly diagnosed. So I think this raises the question of what do we do for the patients that we have today who aren't likely to be able to achieve this? And I think the answer is that we do the exact same thing. We provide them with the treatment options, and we allow them the opportunity to choose an option that puts them on the path to remission or into the process of reversal, the process of lowering A1C below 6.5 as the committee defines it. Even if they don't quite meet this definition of remission, it's possible for them to make incredible improvements in their health. So take, for example, this group of patients, another 30% of patients that we treated for 2 years didn't achieve remission by definition, had an A1C less than 6.5 while taking only metformin. Can't claim remission, but certainly have reverse diabetes to the best that they can. Another 6% achieved an A1C below 6.5 while on SGLT2s or GLP-1s, drugs we now have evidence for use outside of diabetes. And another 2% achieved an A1C less than 6.5 with other meds. This brings us to 63% of patients with an A1C less than 6.5 and meeting the more strict American Association of Clinical Endocrinology glycemic target. 75% with an A1C under 7 meeting ADA's glycemic targets, 85% meeting HEDIS guidance of less than 8, only 6% had an A1C over 9. And I think this really reflects the process of reversal. Although some may never reach remission, I think we can agree that in this context, failure to achieve remission is not a failure at all. And this process of diabetes reversal can benefit many patients. So with that being said, I have just a few key points to leave with you. I'm thrilled that we have a definition for remission to be internationally used, and I'm excited for what we can do with this. From a patient care perspective, a couple of things. I think patients deserve to know that remission is achievable, especially at the time of diagnosis when it's most likely for them to be able to achieve it. Many patients come to us and say, I didn't know this was an option. And I think we have the responsibility now that we have all of this data to change that. At the same time, we need treatment options that serve everyone, even those with long-standing type 2 diabetes. So it's important to be clear that reversing A1C below 6.5, even without remission, but while removing the meds that aren't necessary and removing risk of hypoglycemia, this is achievable and it improves health outcomes for patients. From a research perspective, the unified definition is critical. Huge thank you to the consensus committee for this. Now, I think our next step is to work together across all of the different treatment options that can elicit remission so that we can understand it better. We desperately need comparative effectiveness trials of interventions that enable remission. As the diabetes community moves towards time and range, we also need to understand the relationship between these interventions, time and range, remission, and outcomes. We need to understand the sustainability, or perhaps if there are any legacy effects of short-term remission. We saw this in UKPDS and DCCT, even in the absence of remission, so this might also be true here. And we need to understand the impact of remission on complications and mortality, as Dr. Schauer mentioned. Perhaps if I'm lucky enough, we can even convince Dr. Schauer to expand his DREAM trial to work in an N to include nutrition therapy, not just any old nutrition therapy, but perhaps maybe the best when it comes to sustained reversal and remission. And maybe we can find a spot for this care model delivering carb-restricted nutrition therapy in that trial someday as well. I can't end without recognizing the team that's behind all of this. And with that, I will say thank you for listening.
Thank you, Dr. McKenzie, and to all of the panelists. What we now want to do is turn to some questions. If you do have questions, please put them into the question panel on the Zoom. Dr. Rothberg, let me start with you. The current standards of care actually call for the use of SGLT2s for heart failure, and diabetic kidney disease, and GLP-1s for ischemic heart disease. Are you punishing people by denying them the definition of remission when they're on these drugs for other diseases?
We're not trying to punish people, but we're trying to provide an overarching definition that everybody can use. I think patients are willing to understand that any improvement is critical, and I don't think we necessarily have to achieve type 2 diabetes remission, but it's just obviously unclear if we're on one or many of those drugs that it is not contributing to hemoglobin A1C reduction, as you know, and therefore we really, based upon our current criteria, cannot define remission. But
Did the panel consider at all what the potential implications were from a health economics standpoint or a reimbursement standpoint if you're able to achieve remission?
That was actually beyond the scope of the panel.
Dr. Schauer, your data is really quite remarkable, but I'm wondering about the progression over time, the durability. It looked as though everybody's achieving anywhere from a 60 to 80% one-year remission, but it drops to as low as 16% at 5 years. Clearly, the level of beta cell damage is playing a role, but that's quite a substantial reduction in success in a relatively short period of time. What do you think are the other parameters that result in this recidivism, if you will, in the post-bariatric surgery patients beyond 2 years?
Yeah, it's a great question, Bob. A lot depends on where you start. I mentioned to you those early studies, Walter Pori's and others were getting, 80+% remission. And those are patients with fairly mild diabetes, like the ones who are enrolled in these low carb studies. And there tends to be some reduction over time in all these studies. The 10-year study by Mangroni and Rubino maintained 50% in the biliopancreatic diversion procedure and 30% or 25% the bypass procedure. So I think obviously the extent of diabetes or beta cell function at the time of the intervention, is certainly a key. And the procedure is a key. We had this hierarchy of, glucose lowering effects based on a procedure, with the biliopancreatic diversion the most effective, followed by the bypass, sleeve gastrectomy, and then the band. So the procedure is a factor as well. And then certainly, other factors that the patient may contribute in terms of their own, exercise and dietary, compliance, within that surgical paradigm.
Dr. McKenzie, your data is quite compelling, but a couple of questions. Number one, did you accept all comers in the study, or were there substantial exclusion criteria here? And number two, what's the acceptability of this fairly significant nutritional intervention?
So I think in terms of exclusion criteria, a lot of it was just based on safety. So there's not evidence to support using a ketogenic diet, for example, in pregnancy. So people who were trying to become pregnant were excluded. Very end stages of renal disease and of heart failure were excluded. But otherwise, the criteria were fairly open. So we also accepted patients with long-standing diabetes out to 33 years, which was quite unusual for trials looking at reversal and remission. And then in terms of acceptability, this is open to patients, and what we see generally is that we have no problem signing patients up for it. We were able to recruit our trial very quickly in 2015 when we got it started, and we see the same thing in our commercial population today.
And do people stick with it?
It seems that way, since we had 74% retention at 2 years, and I think this is similar to or better than many other interventions. And the health outcomes are sustained at that point as well. We still had, at 2 years, patients down to an A1C of 6.7 on average, and I think that speaks for it.
Dr. Schauer, coming back to you, given the development of laparoscopic surgery, you've shown that the complication rates come down significantly. What is the level of acceptance of surgery from patients in general, and what are the complications and the surgical reversal rates that you're now seeing?
Yeah, so there's been as I showed in one of the early slides, there's been a steady reduction in complication rates for all of these bariatric metabolic procedures, and for major complications, we're seeing certainly less than 2 or 3% major complication rates. mortality is almost unheard of now. It's well below 0.1. So that puts these operations into this category of what we would call low risk procedures, like cholecystectomy, gallbladder removal, hysterectomy, appendectomy. In fact, gastric bypass comes in a little bit lower than some of those procedures. So we've come a long way, and hopefully we'll continue to get lower. Now, you mentioned reversal rates. Reversal is pretty rare. Reversal rates are well below, 1%, probably in the 0.1, 0.2%. And this is based on, these very large national databases by the American College of Surgeons, known as the MBSA-QIP registry, which all surgeons are required to submit their data. So we have pretty reliable long-term data now, on these complication rates.
Well, I want to thank all of you for joining us today and submitting your questions. We clearly couldn't get to all of them, but we hope that we were able to provide some additional information beyond these wonderful presentations. I want to thank all three of our panelists again today, as well as all of you who attended. I want to remind you that this was recorded, and we will be sending the recording out to all registrants, and you'll receive an email from us with that link. Again, thank you very much for attending, and have a good rest of your day. Thank you.